10 minutes, and I have thousands of slides. So I'm just going to show you a little bit of information and do a little bit of background. So the GERFT process is, if you think of it as management consultancy for medicine by doctors, is the idea. So the idea is, it started off with Tim Briggs doing orthopedics, and he looked at what happened to patients with orthopedics who had their joint replacements, and they compared sites that did well and sites that did badly, and they tried to work out what it was that worked well, what it was that caused problems, and then they tried to essentially learn from that and share their experience. And this has broadly been rolled out across all the specialties, and we've had to try and tackle it for neurology. And in a way, our problem with neurology is that it's rather harder than a lot of ordinary other specialties, because actually one of the biggest problems is a lot of neurological patients are not looked after by neurologists. So we had to think about a separate approach and a different way to look at it. And I'll just talk you through a little bit of the data that we're doing. I'm at the process of writing the national report, which is going to be issued in draft form relatively soon. And it will actually come to all the stakeholders, and the Neurological Alliance and the charities obviously are all stakeholders. So hopefully it's going to contain information and things that you would find useful. And I think hopefully it's going to echo some of David's comments from earlier. And in writing this report, the way we've tried to put it together is we've got 4 different patient journeys. We have patients who get admitted to hospital, an acute admission, and we explore what happens to them. And I'll show you a little bit about that. We have patients who attend outpatients and how they get there, and some of the things that Julie mentioned about the way in which COVID has changed the way we behave about that, and how we can try and optimize that situation. We've then got patients with chronic neurological disorders and the question about what happens to them, what services are available, and what discrepancies there are, and how should we organize them. Because clearly one of the things we're discovering as we go through this whole process is how radically different the organizations of different services are in different parts of the country. And finally, we've got a modest amount of information about very highly specialized services, which are a source of considerable thought and anxiety, but actually obviously involves only a relatively small number of patients. So clearly something very important, but in context, it fits into it's a relatively small part of a large jigsaw. So the first observation, and this is the sort of thing that won't surprise anyone, this is actually taken from the methodology report, which is already published, and this is broadly speaking the number of consultants as compared to their walk-in population across the country, and you can see that actually we've got a wide variation. Now, part of the problem is just looking at a raw number isn't particularly helpful, because you can see Liverpool seems to do terribly well compared to its non-elective population. But as Julie mentioned, they also look after North Wales and the Isle of Man and various other places. So this is an unfair measure. And so clearly a lot of what we've done in traveling around the country is to try and understand the context. But what you can see is that we have fairly dramatic variation. We have, if you live in Lancashire, your access to neurological services is dramatically less than it is than if, for example, if you live in North London. So we have clear and very clear dramatic variation, and we can try and understand some of the ramifications of that. But that's really not the only kind of variation that we've got. And what we've done is we defined a cohort of patients who were just discharged from hospital, acute hospital admissions, with a primary neurological diagnosis, and we try to work out what happened to them. So, the issue here, we've been talking about assessing need. Well, if we define the population rather than looking at what the doctors do, that gives us a better understanding of what services are being involved. And if we do that, and we've got lots of metrics attached to this, but if we then just look at patients who've got in and have been admitted with a neurological problem now for more than one day, and where they are, and these are each of these is a different hospital site. And the darker colours, or the bluey colours, are sites with neurological inpatient beds. And what you can immediately see is that actually the majority of places don't have neurological inpatient beds. So you can see there's quite an assortment here. And within the ones that have got neurological inpatient beds, so these darker, those bluer ones, the ones where the patients are actually under neurology are in the darker colour. And so you can see even within the sites that have got neurological inpatient beds, there's really quite marked variation as to whether you're going to be there. If you're in this hospital, you aren't going to be admitted, whereas in some of these hospitals, you've got a sort of 50-50 chance, and other ones in lower. So you can see a dramatic variation across the country. We've done quite a lot of analysis to try and understand this and to try and look at some of the pros and cons and the different implications as to where this service is delivered. But clearly we've got a very dramatic variation. And the question is, what can we do to try and change that and to improve access? And we had a very helpful conversation with Julie and her colleagues when we visited the Walton to try and think about some of those strategies. But actually the other issue is to say, well, where are all these doctors? What's going on? And just as we had dramatic variation, and these are a series of different kinds of hospitals. So you have, so for example, here, this is a neuroscience center. So that's a place with neurology beds and neurosurgery beds. There are 24 of them around the country. And they look after about a quarter of the hospitals, of the patients that get admitted. Well, about 58% of all the consultants are based at those centres, but they'll also probably look after the places, the DGHs where there are no neurologists based there and they have to depend on people visiting them. So you can see that these patients that are looked after by those consultants. You then have places that have neurology inpatient beds but don't have neurosurgery, and broadly speaking, they provide a service for about the right number of patients. And then you've got places where the neurologists are based there. And in those sites, you can see they've got a fairly large number of patients, but relatively smaller number of neurologists. And what you can see is that all the trainees, 80% of the trainees, are all based at these centres. And you can understand it, there are lots of historical reasons, there are lots of reasons why this has happened. But what it broadly means is that if you're going to be looked after by junior doctors with an interest in neurology, you need to be admitted to one of these hospitals and not to one of these hospitals. And you won't necessarily know which are which. And the question is, how can we change that? Is there a way forward to try and make that make a difference there? There are a whole range of other things that happens in an acute hospital. We've spent some time thinking about the Liaison neurology service. So all the patients at sites that don't have inpatient beds depend on people being able to go and see them as inpatients. And we've looked at the ways in which that's happened and have strategies to try and improve that. We also are very keen that if patients are suddenly ill with significant neurological problems, that there should be a mechanism in place to try and allow them to be seen fairly promptly. And lots of sites do involve neurology, acute neurology clinics, and the sites where the neurologists are based, the neurology centres and the neuroscience centres, lots of them have acute clinics, but actually all the other hospitals, the majority don't. So we've got quite a spectrum of different things, and the question is, how do we involve those? And then obviously we've got strategies and issues about what we do with inpatient neurology services. If we think about outpatients, again, there's a huge range of data that one can present in relation to this, but this just shows that there's a huge inequity of access across the country. So this is the number of, this is from Right Care's data, this is the number of new appointments by CCGs. So each of these is a CCG. So you have some CCGs where they see lots of new patients, and you have other CCGs where they see very few. And clearly this has implications it makes a difference. One of the strategies, one of the issues that has come up, and I think it's been touched on already, is the fact that we have to think differently about how we deal with patients, particularly in the sort of COVID era where things are done electronically. And the notion that actually, if we can provide advice and guidance, we might be able to actually subvert a lot of referrals and actually solve the problem before the patient needs to be seen. So you can actually entirely shortcut the whole process. So the idea is if you have advice and guidance systems, and they're increasingly developed, and we've discussed them as we've gone around the country, a lot of the time you can actually get a response in days with strategies for diagnosis and treatment. Equally, you can identify patients who might need various other treatments or options either quicker rather than going along the blue route, which would be the standard route. So there's lots of opportunities to try and improve these different things. And it's been very interesting to talk to colleagues up and down the country who've come up with different schemes to try and achieve this. So we've talked a little bit about these things. The DNA rate's an interesting thing. It goes up to 20%. And clearly, if you're wasting a fifth of your outpatient appointments, clearly there's a huge opportunity there to try and improve your efficiency. Then thinking about patients with chronic diseases, David's comments about specialist nurse support is very germane, and clearly it's very important. But there are other issues like access to treatments for things like MS and Botox and a whole range of different things. And we've got a few outcome markers. And I'll just show you a few of the data attached to this. So this is the specialist nurse provision according to the different hospital sites. And you can see we've got quite a dramatic spread of access, and you can see that there are 23 sites where there was no support, quite a large number with relatively low numbers of support. So we've got a dramatic variation of the specialist nurse provision, and clearly that's a very important element to the management of long-term care patients. This is a new metric which we've taken from the prescribing for Valproate issues, and this just shows the rate of prescription of Valproate in young women across different parts of the country. And you can see there are some areas that really do very badly, and some areas where the rates are dramatically lower. It's pretty clear that the people up at the red end are too high. We're not quite sure how low should be, but if we're looking for variation, we've got variation, and there's a strong sense that at least part of this relates to the levels of support that patients can get through the specialist nursing and so on. And germane to the MND data that's just presented, this is now looking at the site of death of patients with motor neuron disease, because clearly the notion is that patients shouldn't be dying in hospital. And this is looking at the proportion of patients who die in hospital. And you can see there's really quite a wide variation, with some CCGs having a very high rate of death in hospital. It has to be said, this data is a little old because that's the best epoch that we have. And hopefully we're doing better than that now in supporting patients. So what are we aiming to do? Well, the idea is to try and see if we can actually get an equality of access to all the services and really try and bring everyone up to the best standards. And we've been very impressed with some of the initiatives that people have developed across the country. How can we do that? Well, at least one of the things we're going to have to do is to make sure we do what we do more efficiently, because there's not a lot more money coming in. But clearly, if the stronger our case, the more likely we can try and divert things to neurology. We often get stuck in the queue behind, so cardiovascular, cerebrovascular, and some cancer, and neurology tends to be a little too diffuse to try and attract things. But hopefully we can help make a case to support those things. And the overall drive is that if it can be delivered locally, it should be delivered locally. Not everything can be, but if it can be, it should be. And we need to try and work out how to enable that and support it to be done as well as possible. So that's really quite a brief gallop through some highlights which are going into the report. And thank you very much.
Thank you very much indeed, Geraint. That was fantastic. And